Hey everyone, local anesthesia is like a groundbreaking move in the right direction for the dental hygienist. For years, we couldn't even use local anesthesia on our patients. We would have to wait for the doctor to come in and anesthetize our patients and get our patients numb. And sometimes it wouldn't work, and we'd have to wait for the doctor to come back again. And Oh, so to me, it's like one of the best things that ever happened to our profession is the passage of the laws that allows the hygienists to once again work a little closer to the fullest scope of their knowledge. And so in this episode, we're going to talk specifically about vasoconstrictors and some of the special considerations that you need to take when you are working with a patient who is on a medication or has a complication. Maybe they have anxiety or they have high blood pressure, some kind of complication that would have to change the trajectory of what type of local anesthetic that you use. So it's really important for you to understand how those vasoconstrictors work and how they impact the body, and then some of the considerations that you need to take when you're working with those particular patients. So if that's something that interests you and you want to know more about that, then this episode is for you. Hey everyone, welcome to the Happy Flosser podcast. My name is Billy Lunt. I am your host, and I am here to talk to you about all things dental hygiene to support you on your journey through the dental hygiene program. Welcome, so glad to have you. So you're starting your local anesthesia course, or maybe you're already in your local anesthesia course, or you're getting ready to take local anesthesia. We need to cover some of the basics of pharmacology and vasoconstrictors so that you can have kind of a leg up when you're first starting. You might want to review some of the other episodes that have to do with the basics of pharmacology when you go into local anesthesia so that you're best prepared to take on some of the content that you'll be exposed to when it comes to local anesthetics. The biggest thing about local anesthetics is managing the vasoconstrictors and the patient's health history. So you need to be thinking about how those vasoconstrictors impact the patient, right? We're talking about the circulatory system. We're talking about how the drugs interact. And so it's important for you to make the connection between the basics of pharmacology, of how those vasoconstrictors work, and what the impact is when it comes to a medically compromised patient, especially. So, most dental procedures are done using local anesthesia so that our patients are comfortable. It will reduce their anxiety. It will also reduce your anxiety when you're treating these patients so that you don't feel like you're going to hurt them, especially if you're performing some kind of periodontal therapy procedure where they have a lot of sensitivity or root exposure. It's just so much nicer for you and the patient to have local anesthesia so that you can do what you need to do adequately without hesitation, and your patient can sit there comfortably knowing that they're not going to experience any pain while you're using this, doing this treatment and using local anesthesia with them. So just a couple of basic reviews. An analgesic is a drug that relieves pain while the patient is conscious. And I covered that in a previous episode. I think it was non-opioid analgesics I covered at length. And then an anesthetic is just a drug that produces the loss of feeling or sensation. So these are what we're dealing with when we are using local anesthesia with our patient. And that's just simply defined as the loss of sensation in an area of the body that is caused by depression of the excitement of those nerve endings, right? It prevents the depolarization and the conduction process in those peripheral nerves without the loss of consciousness. It creates that numbness feeling. I often tell the little kids that are getting local anesthesia that if you've ever sat on your leg and had your foot fall asleep and you get that tingling sensation, that's the same thing that they will experience when we use these drugs to numb up a region of the mouth. So, a couple of other terms associated with local anesthesia and vasoconstrictors is vasodilation and vasoconstriction. So, vasodilation is a widening of the blood vessel. Think of relaxation, where there's increased blood flow because those are dilated. There's more blood flowing through those veins. And then vasoconstriction is a narrowing of the blood vessel. This is a tightening of the blood vessel, and this will decrease the blood flow, which as a result also increases the pressure. So local anesthesia is a vasodilator. It increases the blood flow to and from the site where the local anesthesia is deposited. Now think of the causes of this. There's an increased rate of absorption of the drug. There's a decreased rate of the depth and duration of the local anesthesia, and there's increased bleeding, and there's increased blood levels. And some of these characteristics are not what we're looking for with local anesthesia. So plain local anesthesia does not have sulfites. Only local anesthesia with vasoconstrictors contain sulfites. So let's think about why we would add a vasoconstrictor into a local anesthetic. Epinephrine is our most commonly used vasoconstrictor. It increases the duration of use by constricting the peripheral blood vessels. So think about what that would cause. It causes a slower systemic absorption. It provides hemostasis, right? Less bleeding. And it increases the impact or the feeling of the numbness. So it increases the profoundness of the local anesthesia. So as I said, epinephrine is the most common vasoconstrictor that we add to our local anesthesia drugs. It slows the local anesthesia's drug entry into the systemic circulation, which is what we want. We want to reduce that because then it keeps it concentrated in the area for the length of time that we need it to without having to give the patient more local anesthesia. Now, the degree of local anesthesia toxicity is dependent on that rate of absorption and the elimination half-life. Articaine has a really short half-life, about 45 minutes, and has the lowest risk of systemic toxicity of all of the amide anesthetics. So some of the things that are really important for you to know. Local anesthesia crosses the blood-brain barrier and also circulates to all organs. It crosses the placenta and enters the circulatory system of the fetus. This is something you want to keep in mind. Articaine has been suggested for use with nursing moms and has the shorter half-life, like I said, 45 minutes. Lidocaine has a half-life of about 90 minutes. So we use epinephrine in very small amounts in dentistry. It's not ideal for us to use epinephrine because I've talked in a recent episode about the stressful, anxiety-producing environment that the dental office provides our patients. So adding anxiety and epinephrine together is not a good recipe, but we do it because of its impact, because of its effects. Now, epinephrine is absorbed into the bloodstream and it can influence the heart rate, and it can also influence the blood vessels. There are some undesirable systemic effects of epinephrine in dentistry, and they're usually the first couple of minutes. 1 to 3 minutes after you give an injection is when you'll usually see some of those impacts of epinephrine on the body. Now, the maximum recommended dose for a healthy patient is 0.2 milligrams. Medically compromised patients, the maximum recommended dose is 0.04 milligrams. So big difference there. Think about how many carpules that is when you are using that on your patient. We do have some alternatives to epinephrine as a vasoconstrictor. We have levonorepinephrine, and that's a little less effective than epinephrine on adrenergic receptors. It's a weak stimulator of those beta receptors, and we don't have as good of a hemostasis with the alpha, but it is still effective. We all know that epinephrine does a really nice job with hemostasis. Now, the maximum recommended dose of levonorepinephrine in a healthy patient is 1 milligram, and a cardiovascularly or medically compromised patient is zero point 0.2 milligrams. The manner in which the body manages a drug, the pharmacokinetics, right? That's the mechanism of absorption, distribution, metabolism, and elimination. You want to keep the pharmacokinetics in your mind when you're thinking about working with a medically compromised patient and a vasoconstrictor. Now, levonorepinephrine is less potent than epinephrine in raising the blood pressure and acting as a vasoconstrictor. So an example of this, mepivacaine, 20 milligrams per milliliter with levonorepinephrine in it, provides anesthetic of longer duration for procedures. The other thing you want to keep in mind is the pharmacodynamics, which is the relationship between the drug concentrations and the effects on the body. These actions interrupt the normal conduction of nerve impulses. So, local anesthesia, based on an evaluation of the patient, is how we determine which local anesthetic we're going to use with our patient. So, if we have a patient with high blood pressure or other compromised medical conditions, we're going to take into consideration the efficacy, the patient's access, the care plan, the safety. Those medically compromised dosages of epinephrine are important for you to know. This is why it's important for us to update our medical history every visit, take the blood pressure of your patient, and keep in mind that there are drug interactions with some over-the-counter meds, other prescription meds, and recreational drugs. So when you are providing anesthetic to your patient, it is your responsibility to make sure that you obtain an up-to-date medical history and you understand the pharmacokinetics, the pharmacodynamics, and the drug-to-drug interactions that can happen with your patient. Now, the rule of thumb is that it's best to avoid epinephrine when possible and limit it to the lowest effective dose. Don't use the 1 to 50,000. That's kind of a general rule on any of your medically compromised patients. You can still be effective with your treatment by using alternative drugs that don't contain epinephrine in it. And the reason for this is that your cardiac drugs or your high blood pressure patients, when you combine those drugs with epinephrine, you have an increase of the potential for a cardiac arrhythmia with your patient. And it's always best to just avoid the epi with these patients or receive a med consult if you find that you need to use a local anesthetic with epinephrine for your patient. And just as a general rule, anticonvulsants, antipsychotics, antidepressants, and anxiolytics, those drugs, you want to use local anesthesia with caution. And when I say with caution, I mean the lowest dose possible when you have a patient that's taking any of those medications. When I first started using local anesthesia, I was really, really nervous. I'm not going to lie. And I became even more concerned when the doctor would ask me to go into their operatory and anesthetize their patient, because I would have to fly in and review the medical history really fast to make sure that the risk assessment had been done. And I knew exactly what type of local anesthesia to select for that patient to manage them. One thing that became very helpful to me in a practice that I was working in was to have bibs, color-coded bibs, to let you know which patients were at high risk or had a compromised medical history. So we would just use a pink bib on patients that required that consideration, or maybe they had high blood pressure or some kind of comorbidity where you had to use epinephrine with caution. And then we would use blue bibs on healthy patients so that it was easy for the hygienist to come into the operatory and know that that assessment had been done by the doctor. And then reviewing the medical history, those findings would be confirmed. I really liked the easy bib color system. It worked really well. It providing another layer to help protect the patient, reduce the risk, and really create collaboration between providers. I hope that helps for you. Are you looking for study sheets? I've created study sheets that cover the content of this episode. If you're interested or that's something that's going to help you on your learning journey, you can click the link listed right in the description of these show notes. Happy studying! I would invite you to send me any questions that you need answered. Questions come up when you listen to this podcast. I have a link in the show notes, and I'd be happy to answer any questions that you have. Also, I would appreciate a review if you have time to leave one. Thank you so much. Hey, are you in dental hygiene school or just got your acceptance letter and just started dental hygiene school and you're worried about how you're going to fit it all in, what the evaluations are like, what the key strategies you need to set up in order to be successful? You don't want to have worked all this time to get accepted into dental hygiene school only to make some pretty major errors in your first and second semester. I've put together a course that will really help you set yourself straight right out of the gate and get yourself started on the right foot in dental hygiene school. Whether or not you're just entering school or you've done your prerequisites and you're just well on your way halfway through, this course is designed to help get you straight and keep you straight so that you can become a dental hygienist. Click the link in the show notes and check it out.